Okay, perfect. Excellent. Okay. So we're going to talk a little bit about plasticity brain centers, anoxic brain injuries, and there. I know most of you have taken so much time, and you're so ingrained in this community of hypoxic and anoxic brain injury. There's probably not much about anoxic brain injuries or hypoxic brain injuries that I'm going to be able to teach you because a lot of you are so well educated. But I think that there's a paucity or lack of information out there about what to do once an individual has an anoxic or a hypoxic brain injury. So I think that's the direction that I'm going to focus on today. And you'll see there's my name with a whole bunch of letters after my name. And that just means that I spent a lot of time trying to learn how to help people better and expand my clinical toolbox. And I feel like I'm very fortunate to have a background in chiropractic versus medicine, because chiropractic forces you to think outside the box for situations that typically are prescribed medications or surgeries. We don't have the ability to do that in chiropractic, so we have to find other tools. And sometimes, if it's not a life-saving event, other tools are better than medicines or surgeries in order to help somebody get better. More specifically, when someone has a chronic debilitating condition. If I were to, God forbid, get into a car accident and I was about to die, I wouldn't go to a chiropractor or someone that specializes in chronic health conditions. I'd go to the emergency department where I know somebody can save my life. However, once my life is saved, then you want to go to someone who is probably more trained and more skilled and has a better tool set to help somebody manage a long-term chronic condition. So that's where I think there's a really nice separation between emergent care and ongoing care. So we're going to talk more about the ongoing chronic patient, if you will, and how chiropractic neurology, functional neurology, functional medicine, and different types of what we call neurosynergy-based models can help an individual with a hypoxic or anoxic brain injury. So once again, I am a clinician here at Plasticity Brain Centers, but I'm also an associate professor of clinical neuroscience for the Carrick Institute. I am the vice president of the American Chiropractic Association's Council on Neurology, the subspecialty of neurology. And I'm also the vice president of the American Board of Brain Injury and Rehabilitation. So this is what I do every single day of my life, and this is what I love to do. So I'm just so happy that I'm able to share what I do with you individuals watching this presentation. So before we begin, let's talk a little bit about anoxic brain injury, just for the individuals that are not necessarily clear what defines and what causes anoxic brain injury. So whenever the brain suffers from hypoxia, or hypoxia, the word means a lack of oxygen for greater than 4 minutes, they have the potential of having what's called a hypoxic or an anoxic brain injury. The difference between hypoxic and anoxic brain injuries: hypoxic is decreased oxygen, anoxic means without oxygen. So for the rest of this presentation, we'll just refer to all of these as hypoxic brain injuries, okay? So because if you have no oxygen, essentially you have less oxygen, so hypoxic applies to both. So hypoxic brain injuries can be caused by many different things. Many individuals just think that if you maybe had the cord wrapped around your neck at birth, or if you fell into a swimming pool and were drowning in a swimming pool, those are the only causes of hypoxic brain injuries. But that's not necessarily the case. So strokes fall into this category, carbon monoxide poisoning falls in, birth injuries, choking, heart attacks, getting struck by lightning or electric shock can cause a strangulation or suffocation. Even arrhythmias and lung disease can cause hypoxic brain injury. So this whole category of hypoxic brain injury is a much larger category than we really realize. Many individuals can actually fall into this category of brain injury. So to understand how these actually occur, we've got to explain a little bit about cellular physiology, how a neuron, or the smallest unit of the nervous system, actually works. Realistically, what you have is you have a neuron. We'll just call this circle or oval here a neuron. And there's two things that a neuron needs to survive. It needs receptor activation, and we'll talk about what that is in just a moment. And it also needs oxygen. So receptor activation, when you stimulate a receptor, or these are like, we also know them as sensory systems. When we stimulate a receptor, this could be smell, taste, vision, any of these different types of receptors, those receptors take the environment and turn it into an electrical impulse and stimulate or activate a neuron. So there's very specific pathways that happen inside of a cell that causes, in the end, for us to create energy. That's the ATP. ATP, or adenosine triphosphate, not to make it too complicated, is the fuel for every single cell in our body. So if you don't have receptor activation, you can not ATP, which doesn't allow you to have proper cell health, or if you don't have fuel. So the major fuel for our cells is oxygen, glucose, and basically amino acids. So if you deprive a cell of either oxygen or if you deprive it of activation, either one of those things, you can experience cell death. So with hypoxic brain injuries, we know that the lack of oxygen is what causes those cells not to be able to survive, and they die. The mechanism that happens is by not producing oxygen, which doesn't allow your cells to produce energy. Therefore, after a period of time, which we know is defined as about 4 minutes, the cells start to die. So when that happens, we have a whole cascade of reactions. You can almost think about this like dominoes. When one cell dies, what happens is it releases all the chemicals inside of its cells, and then the next one dies, and then the next one dies, and then the next one dies. So we have like a spreading activity of decreased function and also cell death. So this is really, really scary if that's happening to you, because a lot of these individuals that can describe their hypoxic event, sometimes they see bright lights. Like, you've heard the kind of cliche, don't go towards the bright light or the shining light, because what ends up happening is as that part of their brain is suffering hypoxia, it automatically starts to fire off, and we see bright lights in our vision. Or sometimes we can hear people talking to us or hearing the voice of God, so to speak. If you're religious, sometimes that may be an actual thing. If you're not, maybe there's a scientific explanation of it, because the part of your brain that hears voices starts to become active. So we know that what happens to cause hypoxic brain injuries, and we know what happens after hypoxic brain injuries. So now that all of that complicated stuff is out of the way, and we understand the importance of stimulation and oxygen when it comes to brain function, now we need to understand what the purpose or what the function of our brain is. And many people think it's much more complex than it really is in actuality. The purpose of our brain is to perceive the world, interpret it, and respond to it. And then what happens is we then perceive our interaction or our response to the environment. It becomes a cycle, right? So if we hear a door slam, we might interpret that as something that might be coming to startle us. So what do? We turn our head to look at the door to see who's there. And then once we turn our head, our brain has to say, you turned your head, therefore figure out what's going on, interpret it, and then respond appropriately. So you can see how it becomes a cycle. Well, when we injure our brain, the part that we usually lose is the ability to interpret the environment. So if you start looking at an individual who's cortically blind, okay, so cortically blind means that there's nothing wrong with their eye. There's nothing usually wrong with the optic nerves or the nerve that's transmitting the perception of vision to the back of the brain. However, they can't see. So therefore, their interpretation of the light hitting the back of the eye is not interpreted properly. Therefore, they can't respond appropriately. And I hope that kind of makes sense to everybody. So when we have an injury to the brain, the interpretation part of the brain is really what lacks. So when you have somebody that has an anoxic brain injury, essentially you have to put on like your detective cap. And you have to say, okay, every anoxic brain injury is different. Therefore, we must examine every individual and assess every individual individually. So we have to look for clues that tells us, A, what parts of the brain are not working. That's important. But what's even more important, what parts of the brain are still working well. And there's a big defining difference there between the parts that are not working, the parts that are working well, and how you might approach that from a clinical perspective. So if you're trying to figure out how the brain is working, or if you're playing the detective, a detective's going to go to the crime scene and look for clues. Therefore, the neurologist or the physician working with a injured hypoxically injured individual has to look to the brain for clues. So essentially we're playing like CSI, or cerebral systems investigators. That's my little joke there that I like to tell people. So my job every single day in and out is to be a cerebral system investigator or a brain system investigator. So when we look at the brain, there's an analogy or a metaphor that we kind of like to use to talk about how the brain develops. Because if you understand how the brain develops, then what we can do is when there's an injury, we can turn back the clock and figure out how we can get the brain to rehab. Okay, so if you can imagine that a human being is almost like a flower. This is the mother. This is when they have, they're pregnant with a baby. So you have conception. What ends up happening is there's a little seed that's implanted inside of mom. And as you can see, the little spurts growing out. And at birth, realistically, the only part of our brain that really is functioning at a high level is the stem, or we'll call it like our brain stem and spinal cord. So the stem of that plant would be like the brain stem, and those little roots coming out would be like the spinal cord. We know that the roots of a plant allows it to collect all information from the environment, or nutrients and water, and suck it into the brain stem so that everything else can grow on top of that. So if you had a child that was developed cerebral palsy from a brain injury at birth, what we have to do from a crime or a cerebral systems investigator's perspective is look at that brainstem and see how healthy is that brainstem. Now, the brainstem controls a lot of very important things. Excuse me. The brainstem controls how we breathe. The brainstem controls our blood vessel tone. The brainstem controls our gut function and our ability to digest food and move digested food through our gut and our intestines. So we look at all of these different clues from the brainstem to figure out how that brainstem is working. Other very important structures that lay inside that brainstem are the parts of the brain that control our ability to perceive movement of our head, and also the ability to move our eyes in relationship to head movement, called our vestibular system. And one thing that we'll do is if we can go back in time almost 300 million years ago and study fossils of dinosaurs, what we can find is that the structure of the inner ear of a dinosaur is just about exactly the human's inner ears. You know, it's existed for hundreds of millions of years, so it must be very important for our survivability. So it's really important to examine the structures of the brainstem. As a child gets a little bit older, from about 0 to 8 years old, all the nutrients or information that's gathered from the environment comes up the spinal cord into the brainstem, and then allows us to develop this part of our brain we call our cerebellum, or this would be like the leaves of a flower. So from 0 to 8 years old. So if the anoxic brain injury happens, after that time, we need to also investigate how was that cerebellum compromised. Now, what's really important to know is that there's two parts of the brain that are very, very oxygen dependent because they're very highly metabolically dependent. One of them is the cerebellum. The other is the basal ganglia. So for those of you who have seen neurologists with your child with hypoxic brain injury, or your adult with hypoxic brain injury, one of the things that we know is that if something is very metabolically demanding, it's really, really vulnerable to hypoxic brain injury. And the cerebellum controls motor function as far as coordination, and the basal ganglia is very, very important in controlling motor tone. So spasticity or flaccidity is often as a result of the basal ganglia's function. So from there forward, we have the flower that develops. Now, the flower in this analogy is probably what you thought the brain was before we started talking, the ability to do math and speak languages and to be able to interact with the environment, say, "Mommy, I love you," or "I need food." That's all in that very, very high part of our brain we call our frontal lobes. So you can imagine that if something happens very, very low in the brainstem, you maybe never develop leaves, you maybe never develop a flower unless somebody helps you develop through that. If the problem happens at the leaves, you still may never develop the flower. So very often I find that people that are searching for any type of therapies to help an individual with an anoxic or hypoxic brain injuries may go to speech therapy, may go to occupational therapy, which are all really, really good therapies, But all of those therapies are directed towards the flower, to be able to speak, to be able to have fine motor control. Super important for helping somebody develop, but may not be as effective until you address things in the stems and things in the leaves. Hopefully that makes sense. So as a neurologist, this is something that we're taught in chiropractic school. We're also taught in medical school, that there's really 7 longitudinal levels of lesions in the nervous system. So you can have a problem with end organs. These are like when your senses get injured. Peripheral nerves, which are the wires that connect the senses to your spinal cord. It can happen in the spinal cord, the brainstem, the cerebellum, the basal ganglia, things we've already talked about, and also the cortex, which is, if you remember, the cortex is like the flower in that analogy. So these are the 7 areas every neurologist has to examine on every single patient. So some important things that you need to know before we kind of move forward, and what we want to know is what are the essential areas to check in any individual. That's the brainstem, the cerebellum, and the frontal lobe, the 3 parts of the flower that we just talked about. So the frontal lobe, we'll talk about the flower first, consists of 41% of all of our brain's volume. So a large percentage, a little less than half of our brain is made up of the frontal lobe. The cerebellum has 82% of all the neurons in the brain. So it's very, very tightly compacted. So you can see if the cerebellum didn't get oxygen, you can potentially lose 80% of all the neurons in your brain. And the brainstem receives 90% of all brain activity. So if the other areas of the brain are compromised, the brainstem can be compromised as well. And remember, the brainstem controls all of our vital functions. So that makes good sense why 90% of our brain has to make sure the brainstem stays alive. So we can see if we can identify those 3 different areas of the brain and how well they function, we can get a really good idea of how well that individual's brain is functioning. Now, this is also a very important point. Every single one of those 3 structures has a left half that works from the left. Okay, so we have a right side of the brainstem and a left side of the brainstem, a right side of the cerebellum and a left side of the cerebellum, a right frontal lobe and a left frontal lobe. So sometimes different individuals can have more injury to one area of those parts of the brain, or they can have what's called diffuse injury, which means all of these structures on both sides are injured. The results or the outcomes are much better for individuals that have localized dysfunction versus global dysfunction, but we found that we've been able to do some great things with individuals in all different areas. So how do you know if things are more localized or more diffuse in your child or your family member? Well, look at their different signs and symptoms. If they have spasticity, is it greater on one side than it is on the other? If so, then they probably have more one-sided injury. Is their coordination less on one side than it is on the other side? If so, maybe one half of the cerebellum is more injured than the other. If you look at their eyes, you might be able to look at their pupil sizes. If one pupil is larger than the other, then we might say the brainstem is more injured on one side than the other. Or if they sweat more, get more dry skin on one side or the other versus the other, then we can start saying that the injury is more one-sided, which has a better outcome than if things are global. But both of them usually have good outcomes. One just accelerates a little bit quicker than the other, and that's the one where people have more focal injuries. So the question is probably how do you kind of assess all of these different things? Well, step 1 is to do a brain investigation. And the most important tool in a brain investigation is the physical examination. Now, I often, when I talk to doctors, and I teach doctors probably 20 weekends out of the year, I speak at speaking events where I teach doctors how to work with individuals that have brain injuries. And I always tell these doctors that, number 1, your examination is the most important thing. But number 2, an 8th grader can be taught how to do a physical examination. Or to say that differently, an 8th grader can be taught the steps to go through a physical examination. An 8th grader can be taught how to take a blood pressure. An 8th grader can be taught how to check for muscle tone. An 8th grader can be taught to check the vestibular ocular response by turning somebody's head back and forth. So doing the physical examination isn't the hard part. The hard part is being able to make observations of what you see and then take that and put it into a clinical scenario to then create a treatment plan. That takes expertise it takes experience, and it takes someone that really understands the nervous system in order to take those physical examination findings and make something important out of it in order to help that individual. So in order to kind of supplement our physical examination, we also do diagnostic testing. So if an individual is able to stand up, we look at what we call computerized dynamic posturography. So computerized dynamic posturography essentially is a way for us to measure balance. And this is a really good marker of how our brain functions. There's a lot of literature and research to support that balance is a good assessment that's addition to your physical examination if you can perform it. Another is what we call video oculography. Big word. What it means is oculo means eyes, graphy means measurement. So it's a video that measures your eye movements. So we can do this with individuals that may have sustained a stroke in their elderly age, when we can start looking at their eyes and how their eyes move. We can also do these on individuals that have anoxic brain injuries that maybe have been told that they are blind, right, that they can't see. So what we do is we hold these goggles over that individual's eyes. We put them in front of a big screen TV, and we might put a Mr. Potato Head or, some of these different characters that people love, children love these days, and we make the room completely black, and we see if they can track the target. So that tells us, A, are they seeing? And if so, is this just an attention issue, or is it an ability to move their eyes? And then what we'll do is we'll test on this video screen eye reflexes that don't necessarily need a whole lot of brain function to happen. And you've all experienced this before. If you're driving the car and you turn your head and look out the window and try to focus on the trees that move by, or even if you just relax your eyes will go back and forth and create what we call nystagmus. So we have ways to elicit these in adults, in children, in people that have been determined to be cortically blind. And sometimes, actually more often than not, especially because those reflexes go through a different pathway than the pathway that detects, tracking or jumping from your eyes. Sometimes what we see is individuals that are cortically blind have those reflexes, so we know that they're able to see. They just can't do so with the voluntary mechanisms, and that gives us a tool to work with to help them improve their vision. We also can look at these different types of reflex eye movements that bypass the vision part of our brain. They actually use a part of our brainstem. So when you can imagine, and this is called saccadimetry, these fast eye movements are called saccades. You can imagine that when a fisherman drops a lure into the water and it's this little shiny thing, a fish doesn't use its big brain, being facetious here, to say, oh, look at that shiny thing. I better not eat that because I could end up on somebody's dinner plate. What it does is it sees the shiny thing and it turns its eyes to it and just bites it. Because those are really old parts of our brain that live in our brainstem, not in the part that lives in the frontal lobe. So sometimes we can put these children in the dark and laser beams on their eyes, as you see on that individual, and flash laser beams and see if they generate reflex eye movements that are really fast. And once again, that gives us a window into brain integrity and also gives us a way to implement some therapies. We can also do QEEG. So this stands for quantitative electroencephalography. And we currently have a really big autism study going on at Plasticity Brain Centers, where we're running QEEGs and providing individuals with an at-home neurofeedback device. You have to be diagnosed with autism in order to participate in the study, but it's really exciting because we're going to look at how QEEG can measure brain function and then how an intervention can then change brain function based upon QEEG. So sometimes we can even do this with children with anoxic brain injury to confirm or to be a little bit more specific on our exam findings. But don't forget, the most important thing that you can do for any patient, whether it's anoxic brain injury, a concussion, Parkinson's, dementias, Alzheimer's, is have a really good physical examination, because that really determines your course of treatment. This is just all supplemental material that can help either the doctor be more specific or show the patient where the dysfunction lies. We also can do cognitive testing if that individual is capable of doing that. So some individuals that have a hypoxic or anoxic brain injury still maintain the ability to speak. So we can check their problem-solving skills, their memory. So we have different levels of which we can examine or identify a patient's function and dysfunction, starting with the physical exam, then looking at balance and eye movements, all the way up to assessing the flower, if you will, with cognitive assessments using our technology called C3 Logics. So next, people always ask, well, how do you help an individual? So the diagnosis is all good. Many of you already know that you have a diagnosis with hypoxic or anoxic brain injury, but how do we approach this from a treatment perspective? So the second step is we have to create a unique plan. So every care plan should address everything. So you have this picture of a house. And this kind of goes back to the analogy of a flower or a house. Often people are targeting therapies at a high center of the brain, like speech and occupational therapy, which is almost like if you own this house after an earthquake and you replace the roof of the house. However, your foundation is still cracked. You can see the outer walls of the house are cracked and the house is crooked. So putting a new roof on the house, while it might shelter you from the rain, doesn't really allow you to have integrity in your home moving forward. So many of you, if you lived in this house, you would say, well, before I put the roof on the house, I have to make sure the foundation is fixed, and then we can work on the floors and the walls and then put the house on it. So my opinion is that's how we should approach patients. Fix foundational functions before we fix things that are higher centers. So you can see here on this screen, before we talked about perceive, interpret, and respond. So often after a brain injury, and we lose those higher centers of our brain, the only thing that we're left with is what's called a reflex. So a reflex is defined as a sensory perception that has a response with no interpretation. So you probably know some of these reflexes. When you take a reflex hammer, and this is my knee, you hit the knee and the leg kicks, that's a reflex. There's no brain involvement with that. Often we also see that there's a reflex of our eyes and our head where we can turn our head back and forth and see our eyes move. So going through the examination process, we'll often look at what reflexes are intact and what reflexes don't work, because this helps us produce a treatment plan. So the reflex loop helps us to do a couple different things. Reflexes themselves are automatic responses that help us maintain life. So they're very, very important. For example, one reflex is when somebody gets scared, their heart starts to beat faster so that they can get up and run if they were able to get away from the threatening response. But reflexes also help us to develop higher brain function. So for example, every single time you take that reflex hammer and tap somebody's knee and it kicks, your brain then perceives that response and helps it develop a bigger representation of that movement in the brain. So sometimes we can actually use reflexes to help develop brain function. And all reflexes start with a receptor. And this is kind of where we started off. So this is going to segue into how we can actually help somebody with an anoxic brain injury. So on the screen here, you see a record stylus, you see a battery, and you see a solar panel. All three of those things have something in common, and that thing that they have in common is that they take some sort of an environmental energy and turn it into electricity. So for example, in that record stylus, as that record needle is moving along the record and moving back and forth inside the grooves of a record, it takes the mechanical energy of that needle and turns it into electrical energy that can be amplified so you can hear things. A battery takes chemical energy and then turns it into electricity. And the solar panel takes light from the sun and then turns that into energy. So how does this apply to humans? Well, all of our muscles are like the record stylus. When they're stretched and they're bent, it takes the stretching and then turns it into electricity that then stimulates a nerve and allows us to be able to perceive it. Chemicals, we always have chemicals for taste and for smell. Those allow us to take that energy and turn it into electricity, which then stimulates a nerve and helps us perceive it. And then obviously you can think of the solar lights from the solar panels as like light hitting the back of our eyes and turning that into electrical energy. So basically our brain works based upon its ability to take the environment or things in the environment and turn it into electricity. And if you remember on the very first slide, we needed two things in order for our brain to survive and to grow. That one is being oxygen, and the other is being electrical stimulus through receptor stimulation. So how do we exercise the brain? Well, there's really 6 different receptor types that we can use to stimulate or exercise the brain: taste, smell, sight, touch, hearing, and these inner ear receptors called vestibular function. And your clinician or your doctor will, one of those senses needs to be, what is it? You remember it? The physical examination, right? The physical examination is the most important part because that allows us to identify what part of the brain needs to be stimulated. And from our side, we just know which one of those senses goes to where in the brain so that we can target some of those different therapies. So this is more of a complex diagram than you need to be aware of, but essentially what you can realize is that all senses go to a relay center called your thalamus, which then allows your brain to perceive the stimulus. With the exception of one, is smell actually bypasses the thalamus. So I'm going to give you guys a little really important thing that you can start utilizing to really help your children digest a little better. This is one out of many things. Because smell bypasses the thalamus, it goes straight to a part of our brain that's really important for staying alive. So if you can imagine back in dinosaur days and even prehistoric fish, smell exists for an individual to say, okay, do I need to eat this thing or do I need to run away from it before it eats me? So it can smell like pheromones and things like that. So we can utilize that, harness that to help our children digest better. And I know that's a common complaint of individuals with anoxic brain injury is their digestive abilities. So think about this for a second, and you're going to actually be able to experience this. I want you to stop for a quick second, not use smell, but use another sense, and think about sucking on a Sour Patch Kid or a lemon. Basically, like imagine and visualize yourself taking a lemon, putting it in your mouth, and just sucking on the lemon, sucking all the juice out of the lemon. As you think about that, if you have a pretty healthy brain, your mouth should start to water. You should actually start to get saliva pooling up in your mouth. So that's an example of how sensory stimulus or even imagined sensory stimulus can cause us to have an effect in our body, a physiological effect. What is that effect? It's to produce saliva. And what does saliva do? It helps us digest. Okay, so there's another thing that you can do because a lot of times you can't tell your child to imagine sucking on a lemon. One thing that you can do is when you're preparing a meal, and many of you feed your kids through G-tubes, and so you don't necessarily have to cook food for them. You basically puree food and you put it into a syringe, inject it into the G-tube. I would recommend or I would suggest that when you're preparing your blended food inside of the Magic Bullet or your Vitamix or your Blendtec, whatever it is that you use, pull out some olive oil and saute some garlic on the stove as you're starting to prepare the pureed food. Because smell is, for instance, going to allow them to identify this because as we and put it on a gurgle just because of the smell. And what the digestive system before you actually get pure out of their G tube to be able to digest food better, absorb things and move. It's a really important tool we call them or a take-home tool that you can use how you examine on the stove as you're preparing their pureed food. That child is fragrant cooking, and then all of a sudden you can inject them with the so let's take a quick look and just watch this video about how plasticity brains actually implement some of these sensory modalities to create changes in brain function. This is kind of called the neuroscience or the philosophy behind plasticity.
Not so long ago, many scientists believed that the brain did not change after childhood, that it was hardwired and fixed by the time we became adults. But recent advances in only the last decade now tell us that this is simply not true. The brain can and does change throughout our lives. It is adaptable, like plastic, Hence, neuroscientists call this neuroplasticity. How does neuroplasticity work? If you think of your brain as a dynamic, connected power grid, there are billions of pathways or roads lighting up every time you think, feel, or do something. Some of these roads are well traveled. These are our habits, our established ways of thinking, feeling, and doing. Every time we think in a certain way, practice a particular task, or feel a specific emotion, we strengthen this road. It becomes easier for our brains to travel this pathway. Say we think about something differently, learn a new task, or choose a different emotion. We start carving out a new road. If we keep traveling that road, our brains begin to use this pathway more, and this new way of thinking, feeling, or doing becomes second nature. The old pathway gets used less and less and weakens. This process of rewiring your brain by forming new connections and weakening old ones is neuroplasticity in action. The good news is that we all have the ability to learn and change by rewiring our brains. If you have ever changed a bad habit or thought about something differently, you have carved a new pathway in your brain and experienced neuroplasticity firsthand. With repeated and directed attention towards your desired change, you can rewire your brain.
So this video talks more about modeling your behaviors and things like that. But what we realize is that you can create plasticity in motor functions as well, and even involuntary functions. So I'm just going to take 2 seconds and talk a little bit about something I think will really hit this point home. Many of you have heard of Pavlov, right? The psychologist from the early 1900s used to ring a bell and trained his dog to salivate after ringing a bell. So I would suggest, and I think all of you believe this, that most of our children are smarter than dogs, right? So if you can teach a dog to salivate by ringing a bell, if you followed the clinical gem that I just gave you a minute ago, where you sauteed garlic every single time you cooked for your child or blended their food, if you did that over and over and over again, do you think that that can create some changes in their brain that might make their gut work better? I would suggest if Pavlov can ring a bell and make their dog salivate, I think that you can introduce a sensory stimulus using cooking and fragrance to make your child's gut work better. And that's the basis of things that we work on here at Plasticity Brain Centers. Finding the parts of the brain that aren't working well and reprogramming them to work better, just like Pavlov reprogrammed his dogs to salivate at the ringing of a bell. So the question is how do we usually do after 5 days? And I'm very, very proud of these statistics. I'm proud of my staff that kind of works on these things. We see the most challenging cases in the worst of the worst. We see patients that have been to numerous other doctors and haven't received responses. And then we look at them after 5 days, and what we realized is 80%, or about 8 out of 10 of them, improved by on average 50% in just 5 days. So sometimes our children can't communicate these, so we ask the parents to fill out the symptom form. And on average, we see that 80% of them get over 50% better in just the 5 days that they're with us. So we're super proud of these statistics, and I really don't think anybody else in our line of work is getting these types of outcomes. So how do we do it? We do it in what we call our 3x5 model. 3x5 means 3 times a day. By 5 means for 5 days. So many times what happens is people always ask, well, what happens after 5 days? Or I've got 50% better. You know, what about the other 50%? That's where we really rely upon working with your current therapist, your current pediatricians, your current all-star team, if you will, that's working with your children at home. So we do our part and bump them up on average of 50%. And then we say, okay, our goal is to work together with you to create a partnership for the child's benefit. And these are the exercises that we recommend for you. We're going to give you about 10 minutes of exercises that you'll do 3 times a day. Hopefully your therapist will take the first 10 minutes of their session, do our exercises that'll help warm up their brain for whatever is going to come next. And we found that to be very, very, very effective. So we've got another workshop actually on this exact topic. It's going to be a little longer than this. And we're also going to have a tour of our clinic here where you can kind of see some of the things that we do on May 6th. I think it's May 6th. I don't know if we changed the date. But either way, the website there is plasticity5.eventbrite.com. And this is where we're going to have a hypoxic and anoxic brain injury. We're going to also do a little bit of a public service portion of this where we're going to talk about swimming pool safety and things of that nature, because in Florida, we have one of the highest pediatric drowning rates in the country. So we're going to talk about swimming pool safety and what other little things that you can do at home to help your child. Or if you also want to jump in headfirst into the plasticity care model, we're also going to have an opportunity for you to get a little bit of a discount off of the services that we offer here if you attend the workshop. Or if you want to get started immediately, we can maybe have a little bit of flexibility for attending this event. So that's pretty much everything that I have to chat about. So how we just talked about.
Guys, any of you have questions before I field questions that other people had asked me to ask on their behalf? Looks like they both unmuted, so I'm going to guess that they have questions.
Okay.
Okay, well, I'll ask a question that was from another mom. She was wondering why our therapy has a positive effect on spasticity, and what is it that we're activating that's changing spasticity?
Okay, most of the times, let me start from the beginning. The way spasticity occurs is usually there's all of these cells inside of the spinal cord that allows to inhibit motion muscles when one muscle is activated. You can think about this as like, if I bend my arm this way, I have to relax these muscles when I contract these muscles. Those are reflexes that are mediated in the spinal cord. Okay, so that's the basis of tone regulation. However, we have brain pathways that then talk to the spinal cord pathways and tell the muscles when to relax and when not to relax. So a nice simple explanation is that when your brain is not working well, it can no longer send the signals down to the spinal cord, and then all of a sudden you start getting the fingers that come inside the hand, all of this flexed posturing. Usually it's flexed, except if you really injure your cerebellum, then sometimes the posture will go into extension where they put their head back and their arms go out. So to answer your question fully, the reason why our therapies have an effect on spasticity is because we're increasing brain function, which then allows those different neurons in the spinal cord to properly adjust muscle tone. And that's the easiest way I can explain it. There's a lot more to it, if you will, because there's a couple different pathways that regulate tone. For example, there's different areas of our brain that regulate tone in our arms versus our spine. So if we're looking at spinal muscle tone that we need to change, we have to do different things. If we're looking at limb or we call them appendages, right, our arms and our legs, if those are the areas that have spasticity, we have to look at different areas of the brain and different activities. So based upon the presentation, and once again, I can't emphasize enough how important the physical exam is in this process, then we can determine what course of action or what area of the brain we need to work on based upon that to work on the spasticity.
Okay. Another question I had from a mom who is in France, and she's already done stem cells, she's done PT, she's done hyperbaric. She saw a lot of improvements with her kiddo, but she's been very diligent in looking at the research for each therapy that she's done with her child. What type of research are we looking at to determine the efficacy of the therapy that we're doing on these kiddos?
Okay, so I lost you for a couple seconds, but I think I got the whole question. Can you hear me now okay?
Yeah, I can hear you.
Okay, cool. So I think the question was a patient from France got stem cells, did hyperbaric, and want to know how this can be adjunct or a supplemental to those therapies and what we do differently.
Well, yeah, she specifically wants to know kind of the research behind and making sure that we have evidence and, best practices associated with this, I think is, okay.
Okay, so let me just start off by saying there's hardly any evidence that shows that stem cells work. There's hardly any evidence that shows that hyperbaric therapies have any effectiveness at all. And I don't read, Times Magazine, or I don't read Car and Driver or Motor Trend. I read research for fun. So I regularly look through these research for different things. I believe in hyperbarics. I believe in stem cell therapy. However, there's just not a lot of research to support it when you look at peer-reviewed medical journals. Just like there's not a whole lot of peer-reviewed medical journals that support a plasticity model of treatment. Okay, so let's talk about what a plasticity model of treatment is. There's a lot of, this is the plasticity model of treatment. Let's just say it has to do with occupational therapy, physical therapy, vestibular therapy, and maybe, cognitive therapy. So we'll just name those 4 things. Those are the components of a plasticity program. There's a lot of research on vestibular therapy. There's a lot of research on physical therapy. There's a lot of research on occupational therapy. And there's a lot of research on cognitive therapy. But putting them all together, there's not a lot of research. We're actively doing that research right now. As I talked about it a minute ago, we've got this autism study that we're working on. We're doing proactive research with the University of Central Florida, the College of Medicine, to start producing research on the model of plasticity versus the individual components. But when you start looking at stem cells and hyperbaric, because I know that we had a mother on the line right now that did stem cells, and she kind of wanted to know how this could help this. I had a great conversation with this woman, Dr. Dolam. She's a medical doctor. She's got a fellowship in internal medicine, and she specializes in stem cell therapies. And I talked to her about neurological basis for stem cell therapy. We know how it works for arthritis. We know how it works for immune system function. We don't know how it affects the nervous system. So they're doing a lot of experiment with stem cells, and they think that it works. However, they don't have an explained mechanism of how it works. And there's also a lot of individuals that get stem cell therapy that have no results from it at all. And here's the hypothesis that Dr. Dolam and I came up with. When you inject stem cells, they're pre-programmed to go to an area of injury. So if you've got a bum knee, if you've got inflammation, if you've got an immune system disorder, they're going to go to the immune system, to the knee, or wherever. If you've had a hypoxic or anoxic brain injury, the injury occurs at the time of actual injury and for about 1 month after that. After that, there's no more physical injury process going on. Then you're just dealing with the results of the injury. So if you're a year out or 3 years out or 2 months out from a hypoxic brain injury, the injury process has stopped at that point. So you inject stem cells into that body, and the stem cells just float around saying, what do I do? I don't know what to do. And we know, because we already talked about it in this lecture, what it takes to activate neurons, or to say it differently, to activate stem cells to become neurons. We need oxygen and we need stimulation. So a lot of time what they do is stem cells with hyperbaric therapy. What that's doing is that's giving you the cell, and that's giving you oxygen, but what is that missing? Stimulation. So what we believe here at Plasticity Brain Center is if you can catch somebody within 2 months of receiving stem cells, and then we do directed therapies for the part of the brain that's not necessarily working with, now all of a sudden there's a demand on the part of the brain that's not functioning well, so the stem cells are programmed to go to that area, if that makes sense. So now the stem cells can proliferate or grow into that neurological tissue that's damaged. But without the fuel, which all of us are breathing, so I don't really think that's an issue. Without the fuel and without the stimulation, those stem cells cannot convert into the neurological tissue that's injured.
A lot of the
that's our hypothesis.
A lot of the moms from the stem cell that I've chatted with have been given a 6-month window. Is there a reason you say 2 months?
Well, that's what Dr. Dolam, who was the expert that I spoke with, said that that's when they're the most potent, within the first 2 months, but maybe 6 months will be. I know that Dr. Dolam has told me that they've injected individuals with Parkinson's disease with stem cells, and they see results 9 months after injecting them. That doesn't necessarily mean that the 9 months was the time when it's effective. It could have been effective for 2 months, and then all of a sudden those brain tissues are slowly growing back for 7 months. So there's still a lot to learn about stem cells.
One of the moms asked specifically about our experience with children with cerebral palsy. They've had more of a connection with our anoxic population, but not not anyone in the CP population. Can you speak a little bit more with your experience with that population?
Yeah, I mean, this is where it gets a little tough because, and this is not to sound kind of like esoteric or anything like that, but we don't necessarily treat cerebral palsy. We don't necessarily treat anoxic brain injuries. We treat people that have those things. So every person is unique and individualized. So while it might be seeming like you're comparing apples to apples with cerebral palsy, anybody that knows an individual that has had cerebral palsy or does have cerebral palsy, we know that they're all different. But we know there are common characteristics. One of the common characteristics of cerebral palsy is spasticity, right, or abnormal muscle tone. Another characteristic of cerebral palsy is usually uncoordination, so they can't really coordinate very well. So we've seen great changes in people with cerebral palsy with their spasticity, with some of their abilities to coordinate. We've also seen really, really great improvements in their autonomic function. And we talked about this. Autonomic sounds like automatic. This is the stuff in your brainstem that controls your digestion, your blood vessel tone, a lot of things that are very, very important for survival. But past that, every single case is absolutely 100% unique. So there's certain things that we can expect. We can expect to have an improvement in that fight and flight system or the rest and digest system known as our autonomic system. We can expect to see changes in some muscle tone and some coordination, but from there forward, everything else is unique to that individual, just the same as it is with anoxic brain injuries.
Mm-hmm. Another mom on here says, does work specific to one system, for example, vestibular, help functioning in other areas?
Oh, without a doubt. There's so much research on that. And not to kind of interject my interest in this, but I've got and this will illustrate, a point, is there's a lot of research right now that talks about the vestibular system is directly related to the part of our brain that allows us to think. So they actually are starting to think that vestibular function might be able to predict and influence onto IQ or intelligence, right? So if that's the case, we don't really know how far-reaching vestibular system function really is. One of the things that we do know for sure is that when we activate the vestibular system, it can stimulate the brainstem and really change the way our autonomic nervous system functions. And pretty much everybody on here that's listening to this has had some experience with this. If you go to a theme park and spin on a ride, do you only get dizzy? Do you only perceive movement, or do you get nauseous and get a stomach ache and maybe even vomit? So we know that the inner ear vestibular system reaches into the gut. We know that it reaches into different parts of our brain that allows us to have balance and muscle tone. For example, if you do like a dizzy bat race and you spin around a baseball bat and all of a sudden you stand up, what's going to happen is you're going to get more tone on one side of your body and less tone on the other side that causes you to fall over. So vestibular, especially vestibular function, is very pervasive. It'll go through the entire brain and affect all parts of the brain. But that can also be said for other modalities as well. And maybe the most important point is I hate this fact that's not necessarily a fact. And it says we only use 10% of our brain at any time. That's absolute nonsense. We use 100% of our brain 100% of the time to its maximum efficiency. Our brain always strives to be most efficient, so we're always using as much of it as we can in order to stay efficient in the environment.
Okay. In terms of one of the questions I received is based off of the time of the injury. Is that, like, for example, if it happens before a child is 3 versus after a child is 3, because the brain is going through pruning processes, would we be getting better results with one kid versus another? Kind of just, if it's a birth injury, is our results less than if it's an injury that happened later in a child's life, was the main question.
Really, really good question. And I would probably have to answer that in generalities rather than specific. I think in general, younger children respond better than older children. In general, older children respond better than adults that have anoxic brain injury. And I think it's for that reason that our brain is going through almost like a pruning sort of an experience, and we know that there's only one part of our brain that creates new neurons as we get older, and that's called our hippocampus, where we store memories. So after about the age of 30 years old or so, we know that we're not producing any more neurons, and that age keeps getting pushed back further and further. It used to be 18, then it went to 25. Now more research is saying about 30. The only part of our brain that continues to make new neurons is that memory part of our brain. But as a child, our brains are growing so quickly, and we're pruning things. And there's a seizure disorder called Rasmussen syndrome, where the only treatment now that we know of is to do a radical craniotomy, pull out the top of the head, and scoop out one half of the brain, because electrical activity is so chaotic that we can't have two halves of the brain. So neurosurgeons will remove one hemisphere of the brain. That's called a hemispherectomy. And these individuals, if it's done young enough, usually before the age of 3, they can have full movement of their body on both halves of their body, because their brain just rewires so well. So to answer the question, I think younger children do better than older children do better than adults. And as far as mechanisms of injury, I don't really see that there's a mechanism of injury that has a better outcome than another. That's all unique to that individual and the degree of injury that that individual sustained.
Are there any risks that are involved in a child participating in our therapy?
Yeah, absolutely. There's risks associated with everything, right? So some of the risks that are associated with some of the things that we do, since we do a lot of vestibular rehab, there's the risk of nausea. There's a risk of vomiting, which in the about close to 2,000 people that I've treated with our vestibular device, I've never had anybody throw up. I've had people get a little bit nauseous, but that was been temporary. Of course, there's the possibility of sprain or strain injury if we're doing any type of stretching. There's also a chance of having some sort of allergic reaction to some of the conductivity gel that if we do electrical stimulus, people might develop a rash. But that's realistically about all of the side effects that we see. All the rest of the side effects are things that are usually wanted by mom or dad, is that they might increase their bowel movements. They might become a little bit more sleepy and sleep a little longer. They might become a little more irritable. But, that's about it. We don't really do many chiropractic manipulations on these children. So there's not really the risk of some of the things that are associated with a chiropractic adjustment. It's mostly just things that are associated with the risks of physical therapy, occupational therapy, things like that.
How would you set us aside from physical therapy? Because I know that a lot of what they've heard is, us working with primitive reflexes, and a lot of parents are kind of associating that with work that their PT and OT has done. So can you kind of say what's the difference there?
Well, I use this metaphor all the time. I'm an analogy metaphor guy. I mean, that's how I learn a lot of things. That's how I explain a lot of things. That's how it makes sense in my brain. And I think a lot of people seem to get this one. Going to a physical therapist and then an occupational therapist and a speech therapist and your GP, all of that stuff is really, really good, and it's stuff that's needed. However, what we know is that the brain is what's called a multimodal organ, meaning that it takes all of the sensory information from different points and tries to integrate it in order to make sense of it. So if you look at the brain from that perspective, probably the most appropriate thing is to be doing physical therapy, occupational therapy, speech therapy, chiropractic, and all of this stuff at one time, so that your brain can start to integrate it and make sense out of it. And here's the metaphor. It's like baking a cake. So in this analogy, the ingredients would be like the different therapies. So if you got flour, eggs, sugar, water, and frosting, that would be like speech, PT, OT, chiropractic, and other types of therapies. Just because you have those ingredients and you mix them together doesn't necessarily mean you're going to get a cake. And if anybody does any baking, I love to cook, we know that that's the case. You can put a quarter of a cup of flour with 15 eggs and a gallon of milk. You might have something that doesn't resemble a cake at all. So the quantity of the different therapies are very, very important. But also, us that bake know the order in which you combine the ingredients is really, really important, right? We can't put eggs and flour in a bowl, put it into an oven, and then, start mixing milk and then put frosting in it and then put it back in the, so you have to do things in a certain order. The brain is exactly the same way. We need to have all of the ingredients. We need to combine them in the right amount, and we have to combine them in the right order. So that's what makes what we do different, because I'm trained in PT, I'm trained in speech, I'm trained in OT, I'm trained in chiropractic. So it's essentially you're getting all of those things in one place so that we can integrate them all together. And then after this week here, you go back to your individual therapist and they do focal or focus therapy in those areas, which allows that individual to develop at a faster rate.
That is a perfect transition into, so who is the doctor in charge of guiding the treatment? And then also, what specialized training does that individual have? And how well trained is the support staff that's working with each child?
That's a great question. So I'm the guy that's in charge of kind of pulling together doing the physical examination, because on our team, I think that I probably have the most experience as far as experience in diagnostic and therapy recommendation. But my whole team is very, very experienced. There's not a single person on our team that's not a board certified doctor. So there are no therapists, there are no techs. You don't work with somebody that's just got a high school diploma that's doing these complicated and specific therapies. Everybody is a board certified doctor and who has done extensive postgraduate neurology training on the order of 2+ years of postgraduate neurology training. So I go ahead and I do the examination. I work with the clinical team. They're there the entire time. So your child or you are working with me and one doctor for the entire time. So there's no handing of patients back and forth, where somebody might be confused in what the other person was doing. So you get assigned to a doctor. That doctor's in your examination, does all of your therapies, does all of your follow-ups, and you're in communication with that doctor even after you leave. If that doctor has questions or needs to do anything that they can't answer, then they come to me. So I oversee the whole entire care plan, whether it's here or remotely if I'm out of town or something like that. And then those doctors implement my plan and our plan together to make sure that that individual gets the maximum improvement. And the question also was, what is my background? I was traditionally trained as a chiropractor. After chiropractic school, I did a diplomate in neurology. After that, I did a 2-year fellowship in what's called functional neurology. After that, I did a 1-year fellowship in childhood developmental disorders. Then I also did a 1-year fellowship in vestibular rehab. I did a 1-year fellowship in neurochemistry and nutrition. I did a 2-year fellowship in traumatic brain injury rehabilitation. And I also have an honorary fellowship, which is the highest award you can be given in the chiropractic profession, called a Fellow of the International College of Chiropractic. And that's given to individuals that have made a substantial contribution to the chiropractic profession. So, I don't like to talk much about myself, but people would like to know who they're working with, what their experience is. That's a summary of my experience. So multimodal, lots of different types of therapy backgrounds. Oh, and I also got a certification in physiotherapy from the National Board of Chiropractic Examiners.
Okay, this is the last question I have, and it's kind of a hard one because everybody kind of has a different opinion. And so it's about the 5 days. Some people think 5 days seems like way too short of a time to see any gains. And then there's a whole other group of people who think that, 5 days in a row might be too much for their kiddo. Can you kind of talk about that?
Yeah. So the 3x5 is a framework that encompasses probably 80% of our patients. So we need to be able to give somebody some sort of a reference to how long they can expect to be here for. So 80% are within the 3x5 model. We have probably about 20% that may be shorter or maybe longer than that. So, and I bet you if you looked at it shorter versus longer, I'd probably say out of the 20%, 90% are a little bit longer, maybe 10% are a little bit shorter. So with that being understood, everything is customized to the individual. For example, we've had some children that have what we call a very low metabolic capacity, meaning that we do a little bit of exercises and then they just, they fatigue in any sense of the word. Maybe they just can't do it anymore. Maybe they're response wasn't what intended. So we modify our treatment plan. It's no longer a 3x5. It might then be a 6x5. So instead of doing 3 1-hour sessions, we might do 6 30-minute sessions. Or sometimes we get other individuals that need to do a little bit longer. For example, we have some people that come here for 2 weeks, maybe because they're traveling from Australia or Europe and they want to make sure that they get the most out of it. But I experience in trying to play with all of these different models and how many days and how many times a day, this 3x5 is the closest thing to the ideal model that I've been able to produce for the style of care that we deliver. We don't necessarily have patients that say, I can't do full 5 days. And we don't necessarily have patients that say at the end of the 5 days, I definitely need to stay another week because I've made no improvements. As a matter of fact, aside from what our symptom statistics suggest, I would probably say on the order of 97% of all of our patients get better at the end of 5 days in one capacity or another. So maybe their balance is better, but their symptoms didn't improve as much. Or maybe their spasticity improved, but their nausea didn't, or constipation didn't improve so much. Everybody pretty much has an improvement in one area or another. So hopefully that helps answer the question on the 3x5 model. It's just what we find works best.
Okay. Those are all the questions that I had. And guys who are still on the call, did y'all have anything else you wanted to ask? I know it looks like somebody else came on and in the middle of everything. So
I think this is a really important thing, and I also often get asked this, so I'm sure this is going through somebody's head and they just don't know it. My recommendations are all based upon the individual patient and independent of finances. I have nothing to do with finances here. So I make my recommendation based upon what I think that individual needs, and I have no reservations about telling the truth. So if I say on Wednesday, listen, you need to go home because another 3 days is only going to make you worse, or another 2 days is going to make you worse, I give that advice. If on Friday I honestly wholeheartedly feel another week will benefit, I'll make that recommendation whether or not I think that you can afford it, if you can get the time off from work, if your kid can get out of school. I always make the recommendation that I think is best. So I've got no reservations about making an honest recommendation. So when you come in here, there's 2 things I tell all my patients. You can expect us to give 100% effort and 100% honesty. Those are 2 things that are guaranteed here at Plasticity Brain Centers.
yeah, I think that transparency is really important. And I've heard that feedback from a lot of parents that they really appreciate. I remembered something else that a lot of people ask is what level of parent involvement can be, like how much are parents allowed to participate in the therapies?
We want the parents to participate as much as possible because inevitably, no matter what, we're here for 5 days or plus or minus. After that time, we're going to be relying upon the parents doing these therapies at home to give you the ultimate goal, which is much improvement as possible. So the more you can learn while you're here as far as technique and why we're doing what we're doing and what we're observing for, then you'll be able to treat your own child without having to spend money to going to a physician or a therapist. You can do a lot of the stuff at home. So it's really important with the participation. But we also understand that sometimes people are making compromises in order to be here. For example, we have a little, like what we call our relaxation room. A lot of times we'll go in there and the parents just have to be on their laptops working while they're here at the facility while their kids are getting treated, because that's how they're affording to make sure that their kids get the treatment that they need. So as much or as little participation as is able to be given, we accept. So we like to participate as much as possible.
Okay. Well, I'm going to go ahead and stop the recording. Just thank you guys so much for attending. And if anyone wants to email me, I'm happy to answer any further questions.